Just make sure I get your surname correct.
It's Talatala, T-A-L-A-T-A-L-A.
You Dr. or Mr.?
Dr. Vuyiso Talatala.
Thank you. And I see you have a colleague.
Yes, good. Thank you, Chair. I am Dr. Sebulelo Siape.
Siape.
S-E-A-P-E.
Okay, Dr. Siape. All right. Okay. Dr. Talatala, do you want to take us through what you're going to do, or who's going to speak?
Thank you. I will do the presentation, and Dr. Siape will assist me with answering any questions.
Then I will have to take your oath then. Will you just say after me? Are you happy with an oath or affirmation?
An oath is okay.
Oath is fine, all right. So will you say after me, I and your full names?
I am Vuyiso Talatala.
Swear that the evidence that I shall give.
Swear that the evidence that I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
If so, raise your right hand and say, so help me God.
So help me God.
And Dr. Siape, will you also be giving some evidence? Yes, all right. So I should also take your oath. Will you then say after me, I and your full name?
I, Sebulelo Siape.
Swear that the evidence that I shall give.
Swear that the evidence that I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
So raise your right hand and so help me God.
So help me God.
Thank you. Dr. Talatala. Yes. The floor is yours.
Shall I go? Okay, thanks, Chair. We shall be using the slides to assist our presentation.
Yes, we do have the slides.
Yes. And would like to thank the panel for giving us the opportunity to present and for accommodating our change in dates since we were not available last week. The people who were supposed to present, those are the 4 people I would like to introduce us and the colleagues that we are supposed to present with. It's myself, Vuyiso Talatala. I'm a psychiatrist. I'm previously a director of PsychMG. I've been in the senior leadership of the South African Society of Psychiatrists since 2010. In terms of work, I'm in private practice. Dr. Sebulelo Siape is the president-elect of the South African Society of Psychiatrists, and she's also the chair of PsychMG, and I'll explain the relationship of the 2 organizations. Professor Ngcukaitobi is the current president of the South African Society of Psychiatrists, and she is a signatory to the submission. And Dr. Eugene L. Alas is the past president of the Society of Psychiatrists and also a past chair of the PsychMG. The South African Society of Psychiatrists represents about 700 members, mostly psychiatrists, about 600 psychiatrists, and the other members include medical officers and doctors who are in training to be psychiatrists. The Society of Psychiatrists is an umbrella body, and psychiatrists are divided into 2, we call them vocational groups, those who work in private practice and those who work in public practice. Those who work in private practice, their affairs are managed by a board called Psychiatry Management Group, which is PsychMG. And those who work in the public sector are represented by a committee called Public Sector Vocational Group. So the PsychMG manages the affairs of the private psychiatrists, which is probably what we are here about, and does report to SASOP. But SASOP takes the overall direction in terms of the profession. There are 284 PsychMG members. Chair, I want to take you first to the objective, to our objective. Why are we here? But before I go through that, I would like to give you a bit of a...
Let me just get these numbers. What is that 700 that you mentioned?
Okay, the total number of members of SASOP is about 700.
That's the 772.
It fluctuates. It must be 770. The actual figure will be about 772.
Yes, that's what I've got.
Yes.
And then the 284?
Is the members of the private psychiatrists who are
Okay,
members
this
of the psychiatry.
Private.
management.
Okay, so, and the 772 includes public.
Includes public. It also includes doctors who are training to be psychiatrists. We call them registrars. It also includes medical officers who have an interest in psychiatry or are working in psychiatry hospitals, and a few members who may not, who are honorary members, like maybe a president of a society that we have a good relationship with.
Okay, so the 284 are practicing psychiatrists in
Private
private practice.
practice.
Okay.
So I wanted to take you, Chair, if to allow me, firstly to explain why we are here. The Society of Psychiatrists of the view that the forensic investigations by the schemes have been authoritarian, they've been unfair, and they lack transparency. And this is by design. The way the system is designed to be unfair. And a system that lack of transparency, in our view, is that it's a hallmark of a system that is discriminatory. And that happens throughout the world. And we've got examples of such systems in our country, from colonization to apartheid, and we've got European examples, including Nazi Germany. The system itself is designed to be unfair, so that those who are practicing it, or even those who are victims of it, may at times not even realize that they are practicing an unfair system, because it automatically works the way it's designed. That is our view. So, I mean, under apartheid, the police, the prosecutors, the judges, the executive, there was no differentiation, and as a result, the adjudication of cases would be unfair. That is the system we have when it comes to forensic investigations of the schemes. And therefore, our objective and our main submission is that the system needs to be overhauled in full, such that we have an independent, transparent, and a fair system that includes all stakeholders. So what are our submissions to substantiate this, this proposal? Our data shows that there is a racial bias against Black and Indian psychiatrists. Whether this is racism or it's the system design, but we will show it through our data that there's a bias towards Black and Indian psychiatrists. Psychiatry as a discipline is unfairly targeted compared to other disciplines. And we think that that is probably due to stigma against mental health care and stigma against people living with mental illness. And that could be by design, or that could be due to financial pressures, or it could just be due to prejudice. The process followed by the schemes when investigating is unethical, and will show what they've done to us, what makes us to think that they are unethical. And lastly,
one of the presentations said that the difference with psychiatry and other occupations is that from the perspective of the schemes, it's easy to investigate because it's all time-based. Look at the amount of time spent.
If you are biased against a discipline, you'll find it easy. My view is that the cost of mental health care has been escalating. The utilization has been escalating. And therefore, to contain the costs of mental health care, you need to deal with the practitioners so that either they undercharge, undercode, or find a way of really to reduce the utilization of services or the cost of mental health care. I think that's what is underlying. I do not see why would it not be easy to find problems in other disciplines. And secondly, if that was the case, then cases should be, if it was just time-based as the only reason, then we know that doctors work 10 to 12 hours a day. Then the cases we should be dealing with at forensic investigations should be those who are spending more than 12 hours a day. And therefore, we should not have all the unethical things they do. We should just call a psychiatrist, the scheme should just call a psychiatrist and say, you work 18 hours a day. There should be no debate. There should be no calling of notes, all the things I'm going to show you, that to justify that. If time is just the time. So we should say psychiatrists can only work 12 hours and ends there. But when they do the investigations, they go much beyond, way deeper than the time.
Just
In
tell
fact,
me-
they also look for, sorry,
Yeah.
apologies. They also investigate psychiatrists who have not spent more than 12 hours.
In other, the investigations are not only focused on time, they're also focused on other aspects.
Yes.
But just tell me something else. On the issue of the, you say that the cost of mental health care has been escalating, and that is what you think is the reason behind the targeting of your occupation.
I think it's one of the reasons that the cost has been escalating, not because the fees are increasing, not because the doctors are charging more. The increase in fees charged by psychiatrists has been increasing by consumer price index for many years. But what is happening in the space of mental health care, the utilization, more people are coming out and presenting with bipolar disorder or schizophrenia or depression. And because of the increased utilization, the budget spent by the schemes, or even government for that matter, is increasing for mental health care. And that is not a psychiatrist problem. It's a good thing that people are presenting, but it's the problem that the country should deal with in terms of budgeting.
Is that more people coming out? Is that a shift in the change in the disease burden? Or is it just that those patients are becoming more aware of their ability to seek mental health services?
I think this is my opinion, the biggest contribution is people getting aware of the services. I work in Soweto, in a black population. I am busy all the year round because of, and over the years, the numbers have been increasing, and I'm busy because of people becoming aware of the illness. Obviously, South Africa has got other problems that make mental illness be more prevalent, whether we're talking of violence or financial problems and all that. But I think people are becoming aware of the resources available to them. And also, the more we train psychiatrists, then the easier is the access, and the more people will then seek help. When there was no psychiatrist in Soweto, or there was one psychiatrist, then people get tired of waiting for the psychiatrist. But if there's 5 psychiatrists as we have now, then people will present themselves.
Yes, Dr. Siape.
Yes, thank you, Chair. I was just adding on the question of, you had said time-based. It's beyond time. I think psychiatrists and the mental health care user is the more vulnerable group, so they present themselves as an easy target. They are not a vocal, vociferous group that will put up a march, write a petition, if a service is against them or they're not getting the services that they deserve. So in that manner, they're easier to launch against. And even beyond time, generally in psychiatry practice, we use very few codes. I think averagely about 13 codes are used all the time, if not less. Unlike if you look at a surgeon or a physician, there are millions of codes. So it should actually be easier to follow what the psychiatrist is doing, because we have very few codes.
Just tell me, when you say, look, the escalation in usage, is obviously driving the cost up, and there may be other underlying reasons why the usage is escalating. Where do you get this from? What's the data? What's the information? Is it just your own speculation, or is there something tangible?
We don't have the data ourselves, but one can see in the practices on our own experience. But the schemes themselves have shown when we are in meetings, they've shown the increase in utilization. In fact, the schemes would be able to provide that data.
Can I add, Chair, that also that information should be easily available, because if you look 5 years ago, 10 years ago, there was a very small number of psychiatric beds, and now they've over tripled. So that, and I'm talking about just inpatients. And so and there are always 4. It's not unusual that you have to wait for an admission bed when you're unwell.
Thank you.
Thanks, Advocate. So we, have I covered that? So we, just get myself. So we said there's a racial bias, that's how we submit that, and we submit that psychiatrists are unfairly discriminated compared to other schemes. The process followed during the investigation is unethical, we'll show that, and then there's bullying. Once we say all this, we put all the submissions, we want them to be taken in context, that this is based on our experience with these investigations by schemes. We are not inviting the schemes to investigate white psychiatrists or to investigate other disciplines so that they can put them on par with the vulnerable or discriminated people. And we are not in denial of the fraud. In fact, we do accept that health is vulnerable to fraud. Mental health is vulnerable to fraud. And we would want fraud to be singled out and dealt with. And that's why we want the overhaul of the system. I'm going to now substantiate why I think that there's racial bias, and we're going to use the data of our members. As I've said, the real experience of an actual psychiatrist being investigated was 2008. Dr. Eugene Ellis was involved at the time, and I think I started getting involved around 2010, 2011 as a chair of PsychMG at the time, and I've been involved for over the years. Dr. Siape has also been involved. Of course, because we're doing this after hours, it's difficult to be involved consistently all the time when there's other challenges. I want to take you firstly to the demographic data of our members. You don't have to pay attention to the provinces, but if you look at the top row, there's blacks, coloreds, Indians, and whites, and total. At the bottom is the total of each. So we've got 64 blacks, 7 coloreds, 66 Indians, and 147 psychiatrists. We're talking just about the PsychMG, the full-time private practice psychiatrists. So total number, we've got 284 psychiatrists. So if you put blacks, coloreds, and Indians together, we've got about 137 black, colored, and Indian psychiatrists and 147 white psychiatrists.
Mr. Talatala, just to ask a factual question, do you know how many psychiatrists there are in private practice in the whole of South Africa? In other words, who may not be a member of PsychMG?
What's the exact number?
The exact number, sorry. The exact number, but I think there's about another 100 that are not members.
Yes. But we do have I just omitted to think about that when preparing, but we can submit the exact number of the total number of psychiatrists who are in private practice. The extra 100 does not mean they are all in full-time private practice. We can submit, then they're in private practice, maybe they're not full-time, retired, so we can submit that data that shows who is in full-time private practice, working full-time, part-time, whether they are PsychMG members or not PsychMG members.
That would be very helpful, thank you.
Yes. So in terms of the PsychMG members, therefore, we've got 52% white psychiatrists and 48% black, Indian, colored psychiatrists. In this slide, we are then dealing with the number of investigations per race. This is not the number of people. This is the number of the actual investigation, where the investigation has taken place. There are psychiatrists who have been investigated 5 times once, one person investigated 5 times, and nothing ever found. So that's the total number of investigations. So black investigation, it's 45, colored 1, Indian 40, and psychiatrists and white psychiatrists 34. So the total number of investigations that we've had is 120. That is looking, I'm going to then analyze that data further. So I'm looking at membership versus the forensic investigations.
Over what period is this?
Since we started, since
Over
2008.
the last 8 years.
Yes, since 2008. But of course, the number has been increasing over the years. There have been more and more over. You may have had one in 2008 and had nothing for a couple of years, and then they increased over the years.
Sorry, just to be clear, 8 years takes us to 2011.
No, since 2008.
Okay, so it's 11 years worth of data.
Yes,
Thank
yes.
you.
Now, if you look at page 2 of your submission,
What's it?
say that SASOP has been aware of forensic investigations, audits, reviews of psychiatrists by medical schemes since 2008.
Yes.
And then when you deal with the data, you say over the last 8 years, there has been 120 audit cases in which 74 psychiatrists requested assistance from PsycMG.
Okay, I think,
Which
sorry.
is that data at
yeah,
2.1.
I think we should look at the 8 years. I think before, I suspect that before, beyond that, we didn't have capacity to capture it correctly. And there were not many cases, but we didn't have what changed in the society is that at some stage we then hired a company to actually assist us to keep data. And so I think when we're preparing the document.
This is not a problem. I think the only issue is just to get clarity whether this data is from 2011 or from 2008.
I think, I think it's probably from 2011. Yes. And we can further just verify that so that we are solid. I think it's from 2000, it's past 8 years. It's our experience in 2008, but I think we became solid in capturing the data in the past 8 years. So in this slide, we then look at the demographics of the investigations. As I said, there's 45 black psychiatrists, black investigations, 1 current investigation, 40 Indian investigations, and 34 white investigations, leading us to 120 investigations. If we then drill down in the data, the number of members per race category, I'm taking you back so that we have everything in one slide. We said we've got 64 black psychiatrists, PsycMG, 6 colored psychiatrists, 6 Indian psychiatrists, and 147 white psychiatrists, which gives us 284 psychiatrists. The number of investigations per race, so out of the 64 black psychiatrists, there have been 45 investigations. And out of the 6 colored psychiatrists, there's been 1 investigation. And out of the 66 Indian psychiatrists, there have been 40 investigations. And out of the 147 white psychiatrists, there's been 34 investigations. If you look at the members that actually got investigated, because I said those were just the number of investigations, there could be duplicates or even people investigate 5 times. Out of the 64 black psychiatrists, there's been 23 psychiatrists investigated. Out of the 6 colored psychiatrists, there's been 1 colored psychiatrist investigated. And out of the 66 Indian psychiatrists, there's been 25 investigated. And out of the 147 white psychiatrists, there's been 25 psychiatrists. And that brings us to 74 psychiatrists, the actual psychiatrists investigated. From that slide, it shows that whilst the white psychiatrists are more than double the number of Indian psychiatrists, for instance, the Indians and whites have had the same number of psychiatrists investigated. And the black number is almost equal. The percentage of members per race, I'm just going back to the first number, we are 22.5% black psychiatrists, 2.1% white psychiatrists, 23.2% Indian psychiatrists, and 51.8% white psychiatrists. But if you look at the number of investigations, the investigations are displayed such that there's 37.5% investigations amongst that are taken by blacks on behalf of psychiatry. There's 0.8% taken by white coloreds on behalf of psychiatry, 33% taken by Indians on behalf of psychiatry, and 28% taken by whites on behalf of psychiatry. And if you look at the individual members, the actual psychiatrists, the distribution also shows that there's almost equal number of people, of psychiatrists investigated across black, Indian, and white psychiatrists. The last line, we analyze the percentage. What is the percentage of psychiatrists investigated per race? Like, what's the impact of investigation per race? So there's 35.9% black psychiatrists investigated as a group. So if you're a black psychiatrist, you've got a third of a chance to be 1 out of 3 psychiatrists will be investigated. If you look at Indian psychiatrists, we've got 38.9%, which is about 38%. Over a third of Indian psychiatrists in the country have been investigated. But if you look at the white psychiatrists, it's 17%. Despite the fact that white psychiatrists are a bigger pool, 50% of, over 50% of psychiatrists. So I'm just reiterating that. So the total burden of investigation that has been taken by black, Indian, and colored psychiatrists is 72%. And the total burden taken by white psychiatrists has been 38%. That is despite the fact that the two groups, if I were to separate white psychiatrists as a group, are almost equal percentage in terms of membership. So we further submit, if I may move on, that the stigma and discrimination of psychiatry and mental health, 120 investigations, not psychiatrists, 120 investigations to psychiatry, which represent 20% almost, or 40%, 42% of psychiatrists. If we were to compare ourselves to other disciplines, that is the list we got from our management, a company that manages PsychMG, and SASOP, but also manages other disciplines. I'm going to take you to the surgeons, the Surgicom, the FCPSA, the FCPCSA, which is the physicians, and the gynecologist, GMG, and even the pediatricians. If you look at all those disciplines, each discipline has more numbers than psychiatrists. I mean, if we had less physicians than psychiatrists, the country will be a disaster. But if you look at the numbers investigated, for the gynecologists, it's been 46. For the physicians, it's been 22, the total number. For the pediatricians, 9. And obviously, I'm not inviting that they must be investigated, but I'm just showing that for psychiatry, even the second discipline, specialist discipline, has had 46, and psychiatry has had 120 investigations.
Dr. Talatala, do we know the numbers of the membership of each, the total number of membership of each of the disciplines?
That was error on our side. We didn't put it, but we can submit it as well. But it's definitely more than psychiatrists. As I say, if we had less, if we had 600 physicians or in the country, or 600 pediatricians, or 600 surgeons, that would be a disaster. There are definitely more than psychiatrists.
We could get the numbers that would help us to compare.
So in terms of the outcomes of investigations, we can summarize that there's been 34 audit cases where anomalies were found, and the doctors had to refund the medical schemes, which is about 28.3%. There's been 66 audit cases, which is 55% of all total cases where no anomalies were found, and the medical schemes accepted the feedback and explanations from the doctor. That is a very important figure in my view, because it shows that the schemes have a fishing expedition in psychiatry. The psychiatrists are not practicing, expecting, for a long time, we have not trained them to practice a defensive, a practice of psychiatry that anticipates that they will be audited, because we don't have auditing of psychotherapy. So they are just practicing as usual. So if they were able to prove that no anomaly has happened in 55% of them, to me that says that there was a fishing expedition by the schemes. And remember that even the ones who accepted, it is not certain that they had done anything wrong, because when the investigation is carried out, if the doctor does not cooperate, then the payment stops. And obviously, the financial dynamics between the doctor and the scheme stops paying. And we don't have many schemes. It's not that if one scheme stops, you are losing 10% of your income. No, if a scheme stops, you're probably losing 50% or 40% of your income. So it's very difficult for psychiatrists, for any doctor, if they are being investigated by the scheme, to not agree to sign and pay whatever money they've asked for this, your sake as a practitioner and for your patient.
I mean, of that 55%, I mean, we've seen the slide before. I think it came with Clink or something, but one of the professional bodies. The question I asked them is, out of that 55% which was cleared after the investigation, how many do we know had their payments suspended during the investigation?
Oh, we wouldn't know. I wouldn't know at this time. We can look for it as well. I wouldn't know. We wouldn't know how many actually got suspended. It's a threat that gets put, and if you don't cooperate, then they would suspend. But if you cooperate, they wouldn't. But at some stage, there was a time where some of the schemes, and I didn't bring that, they would suspend even before they tell you that they are investigating you, and then once you. Then you'll stay suspended until the matter is resolved. But we did not look at that. I'm not sure if we actually have kept that kind of data.
And in relation to the 28.33%, where no anomalies were found, where anomalies were found, what type of anomalies were those? Was it fraud, waste, or abuse? Or something completely different?
I'm just thinking off my head now what schemes have found. Psychiatrists would accept, or even if they don't accept, would sign agreement that they'll pay where they've been accused of spending less time with a patient. I think that's the main thing.
Yeah, it was the time that the scheme said the time was not enough, and I think that was the main thing. And then the codes, because you see the time and the codes, the code depends on the time. So the scheme will then work out that no, this couldn't have happened you couldn't have seen this patient in this time. And what then happens is that they extrapolate, and he'll talk about it later. If let's say, for example, that they find 5 patients, then they say, therefore, that means that this percentage of your practice is not keeping up to the right time. So they extrapolate from a small number to include the whole practice, and then they sanction you on the whole practice.
In fact, you are reminding me, the dispute will be actually that it's not even time. The dispute will be about the code, how the psychiatrist interprets the code, the scheme interprets the code, and how the society interprets the code. That's where the dispute starts. And in all settlements, will settle with the scheme's interpretation of the code. And therefore, because of the scheme's interpretation of the code, which differs with the psychiatrist, and the code is time-based, then the psychiatrist then will be made to pay back. But we'll still further explain that.
In relation to this information about the 66 audit cases, where the 55% of total cases, no anomalies are found, those are effectively false positives, as I understand it. The scheme's evidence would be their system flags a practice for audit, and then they investigate, and then they get a result. But what you are presenting to us is that system is producing 55% of false positives. Am I correct?
Yes, that's correct.
So do you know the breakup of the schemes in question here? Who is responsible? Which schemes or administrators are responsible for producing this false positive?
I think now I'm just we actually do have the data as well. Unfortunately, I didn't bring that as the breakdown of the schemes. But from my experience, all the schemes that investigate will have the false positive.
Perhaps we can just get that information.
Yes, we can get that. So for us, if I may continue, Advocate. Yes. Yeah. For us, we believe that there's humans behind the numbers. Maybe for the actuaries and the designers of the systems, the numbers are more, in fact, even to the economists and people who run big business or even government, the numbers are more important than the human beings. But for us, the human beings are more important. And who are those human beings? I will talk about the psychiatrist and the family. And I want to show this. When the scheme, when there's a dispute between the scheme and the psychiatrist does not accept the methodology of investigation, and the scheme stops paying the psychiatrist, immediately the patients cannot afford the psychiatrist. A huge number of patients would not afford to see a psychiatrist unless they were on a scheme. When they then stop paying the psychiatrist will be difficult to even see the patients for free for the time, because it won't be just 10% or 5%, it will be 40 or 50% of the actual practice. What then happens to those patients is that they will not have access to medications. Some of them, the illness itself made them not to trust the psychiatrist in the first place, so there'll be a breakdown in the therapeutic relationship between the psychiatrist and the patient. Most of them are working for the bank, working for different industries. If the patient was in hospital last week, the bank wants the sick leave note. They want a report why remember, the patient is already discriminated by the work environment. So if the employer, I'm sorry to pick on the banks, but the employers, almost all of them are like that. The employer is already not believing that you are in hospital as a mentally ill person. So, and therefore they want evidence. Probably they even want an affidavit, but they don't. But they want solid evidence that you are in hospital. You cannot come and tell them a story that my psychiatrist is not seeing us now, and therefore I cannot produce the report that we want. And if that patient then moves to the next psychiatrist or to the public sector, to a clinic, the public sector clinic, the psychiatrist at the public sector clinic will not be able to account for that time. And therefore, this affects the patients in the workplace. Obviously, I won't waste your time, Advocate, with the impact of this financially to the patient and financially to the family, to the community, even to that employer who's distressed because they don't know how to accommodate this person. Maybe they had an insurance to cover the time the person was away at work, but they cannot claim for the insurance. They cannot hire a new person. So it affects the system. This investigation and stopping of payment affect all of us. And we are of the view that...
Sorry, just to clarify, by stopping of payment, you mean being put on indirect payment, so that the patient would have to pay you upfront and get reimbursed by the medical scheme. Is that right? Some
of the schemes will put you on indirect payment where the patient can pay and then get an invoice and go and claim. Other schemes would stop payment. They say you mustn't see that. They don't tell the patient that they mustn't see you, but the patient they won't refund you if you saw that psychiatrist that they're not paying. But even the indirect payment, even if you have to say the psychiatrist is going to choose, the scheme is going to choose to stop the indirect payment, that is still destructive, because most of the low-income families will not afford to pay the psychiatrist upfront. In fact, actually, I can say almost 90% of psychiatric patients rely on the people living with mental illness rely on the schemes to get their treatment. Very few people living with mental illness will afford to pay cash for mental health care. And I know this because actually most psychiatrists, almost 90% of psychiatrists are in an arrangement they take up, almost 90%, they take up the arrangements with the schemes. They take them up even before we recommend them, because there's pressure from the patients who cannot afford to pay cash for mental health care. So we believe that stopping the payment is insensitive, is reckless, and it really does affect the care of the mental health care users. Now I'm going to show the stigma, further evidence of stigma against psychiatry by the schemes. When people have a mental illness and they get put on treatment, it is well known that they'll have weight gain from the medications, but also the illness itself puts you at risk of other illnesses that may result in weight gain, for instance, as an example. But a lot of schemes will not fund dietitians if dietitians are treating for instance, in a hospital, a patient admitted with a mental illness. If you refer, the dietitian won't be paid, and yet that is key treatment for at least the adverse effects, the side effects of the medications used. Most schemes have stopped paying for physiotherapy. They will not pay for, some of the schemes will not pay for physiotherapy, even if first 3 days you were in the medical ward and you were diagnosed with a medical illness that needs physiotherapy, and you can then get transferred to a psychiatry ward because the psychiatric illness is weighing heavier than the medical illness, but you still need physio for your lung problem. When you get in psychiatry ward, that's the day the physiotherapy stops. Obviously, a lot of schemes have stopped paying for physiotherapy when it's required for mental illness. For instance, if you've got depression, which is known to cause pain scientifically, and the pain of depression, you cannot treat it with painkillers because the patients will get addicted to the painkillers because it doesn't go away. So the pain of depression needs physiotherapy. But if you ask the scheme to pay even for a condition for bipolar disorder or depression, something on prescribed minimum benefit, a lot of schemes, not all of them, a lot of schemes will not pay for physiotherapy in whatever form, and which is further discrimination. At times, this is not always, when you've got, if I admit a patient in the medical ward, in the psychiatric ward for a depression, and the blood sugar is not supposed to be going up, which is common in mental illness, and the blood pressure, and you ask for a physician to come and see, physicians refuse because physicians don't get paid. So probably you have to discharge the patient to the patient go and see the physician, and then the patient comes back. So I think the finances have influenced, made the medical aids to lose the sensitivity and the appropriateness when it comes to treating mental illness. I am moving on to submit that the process itself, but that's followed by the schemes, is unethical. And I think that is due to stigma and lack of care. Schemes believe that they can follow an unethical process because the mentally ill people will not complain anyway. Or it doesn't matter. I don't know, there are reasons why they would not follow the ethical processes, and I'll show this. Firstly, I'll start with the process. The schemes, they make the rules regarding the investigations unilaterally. They determine who should be investigated. They carry out the investigation themselves. They employ their own methodology. But remember, these are the people who are supposed to be, they're almost like an insurance, they should be paying. They do not share the data to verify that a healthcare professional is an outlier. If they say, you are seeing too many of this code versus your peers, you don't know, the psychiatrist doesn't know who his peers are. In fact, if we had shared that data upfront, then probably the psychiatrist would have noticed that in my hospital I do too many scans of the brain. Why am I doing more scans than other people? They would have noticed that themselves and learned from it. But the schemes won't tell you that you're an outlier.
Can you just tell me, have you ever seen a case, I mean, how is a case actually resolved, you see? Because you start an investigation and you're talking here about finding someone guilty, but there's no third party that is going to impose a verdict of guilt. And there's no third party that will impose a sanction for being guilty. My understanding is that there are really two ways in which a case is concluded. One is they find that there's no evidence, they are satisfied with your explanation. The other is that you sign a settlement agreement. There's just no other way of concluding a case. What is your experience?
It's not a settlement agreement. I've sat with psychiatrists.
It's called an AOD, but
yes. Maybe that's how it's concluded. But why we're saying there's guilt is that when there's a hearing, they'll call the psychiatrist and they will put their allegation that you've done this, this, and that, and the psychiatrist would explain that they've done it differently. But that wouldn't matter. Then they will then make a finding that you are wrong, and therefore sign the settlement. So it's not a settlement that we are agreeing that we don't want to take this thing further.
But I mean, am I right that there are really two ways of concluding the case? The scheme accepts your explanation, or it doesn't accept your explanation. Where it doesn't accept your explanation, the real option you have is that the scheme might suspend your payment, put you on so-called indirect payment. Alternatively, remove you altogether from the practitioners that are recognized by the scheme. But if you don't want either of those, you sign an AOD. That is another way of concluding the case.
I think that's how they concluded. Yes, that's how they concluded. But remember, at the time you are signing that settlement, it's not that they've pushed you signing it. Because
I accept that you may sign it even if you don't believe that you are guilty.
Yes.
I'm not saying that a case has been concluded fairly, but a case is brought to an end either by the scheme accepting your explanation or by the doctor signing an AOD, even where a doctor protests their innocence.
Yes, Advocate. The other way, in this next slide, I'm substantiating the unethical process. The first one is calling of patients to verify services. So if the scheme wants to know whether the patient was actually seen, they have in the past called a patient and asked, did you see Dr. So-and-so in May or in January? And they'll ask the time and the details of the consultation. We've protested and objected to that. Some of them have stopped, but the problem that we had with that is that they would then use that call as evidence that the patient was not seen according to the time that has been charged. But it is impossible to remember, as I don't know how much time I've been here, sitting here, it is impossible that when you are in a psychiatric consultation, you would remember how much time you were sitting in that consultation. It is worse if you then asked, how much time did you sit in that consultation 2 weeks ago, a month ago, 2 years ago, or 3 years ago? The investigations usually last for a 3-year period. They look at patients for a 3-year period prior to the time you are investigating. And also, it also does affect, the calling of the patients does also affect the therapeutic relationship between the patient and the doctor. Because if they are disagreeing, especially if there's pathology in the patient, then it becomes, it does affect the treatment of the patient. That's why we feel that's unethical. The second one has been...
Sorry, Dr. Talatala, which schemes do this, call patients?
The one that has done it, and we fought over years, and eventually they agreed to stop, was Discovery Health. Then there's the...
Did you correspond with them in your engagement and your discomfort about this procedure they used? Or how did you engage with them?
We met several times. There would be emails. We have, because we have put it in writing. There will be emails between us and them. I think if we were to look back to our records, because this didn't happen over a short period of time, it happened over a prolonged period of time. So there would be emails. So we spoke to them in meetings, and there would be notes of meetings. And I think if we look, there will be emails where we're protesting the.
Would you be willing to share that with us?
Yes, I would be.
My understanding is that you say they stopped. They no longer call patients as a method of investigation.
Yes, they told us that after many years, they then stopped calling the patients. They said they stopped.
Just to clarify this point, I'm reading from your written submission at 3.1, but it's not entirely clear from that submission if you, and perhaps just let me ask the question and you can make it clear, but whether you object to the calling of patients per se to ask anything, i.e. to ask whether you went to the consult or how long the consult was, or if your objection is that you object to calling patients to verify the time for the consult. Please, can you just clarify that?
Object to verify the services.
So across the board, so both if you're going to try verify time or if you're going to try verify whether a consult occurred.
I think they can say, is Dr. Talatala your doctor? That would be fine. If I have to explain, I don't think that it's their members, they can say that. But what would be a problem, if I'm not putting it clearly, is where they phone one to ask the time or the content of the discussion in that therapeutic session.
So is your submission it's permissible to phone a patient to ask if you saw the doctor?
I think because they are paying, they would know, obviously they would know that you are, I don't think there's any confidentiality there, because they would know that patient X has seen Dr. Talatala, it's in their information. If they can phone and say, did you see, is your psychiatrist Dr. Talatala? That's fine. If they do that even sometimes to help the patients. You know, they've got their, some schemes have got in-house, they make them patients join a program and then they phone them to support them. So I don't think we can say they mustn't phone patients at all. They can phone for various reasons. But it's to deal with the content of the psychotherapy session that has taken place.
We have heard submissions, and I now can't recall if it was from a psychiatrist, but it was in relation to psychiatry where the objection was calling patients at all because patients may be mentally ill and may not properly recall events.
So I didn't hear the last part.
So we are saying we have heard submissions, and I can't recall if it was from a person practicing psychiatry, but it related to psychiatry. And the objection was that schemes or administrators were calling patients who were mentally ill, and that was per se unfair because those patients were mentally ill and potentially couldn't recall events. Or, yeah.
I don't think it's unfair to call them, but it's unfair to deal with the content or to even use the content of the information to justify whatever the reasons. I mean, the patient can be, let's assume the session ended on a bad note, which does happen in our profession. That the patient says, I walked out after 1 minute, cannot be concluded that that is for sure the truth. Or maybe the patient is telling what they can actually remember. As I've said, I can't remember how much time I've sat here as is.
No, I was saying that with regard to the calling of the patient, as Dr. Talatala has mentioned, if they were just wanting to know who is your psychiatrist or are you seeing your psychiatrist or something like that, it would be enough. But unfortunately, the schemes, especially if I may enumerate discovery, that's not, the point is not just to see that you've seen your psychiatrist, but it would be the issue of time. And really, time is very difficult to measure when you are not aware that that's going to be an issue. Number one. Number two, the average person who is consulting with you is in distress. So to remember time is not necessarily what they're going to do well. Thirdly, patients need their medical aids. And when the medical aid, it's sort of like your authority, they phone. You feel desperate because you don't want to lose your medical aid. And patients, the average patient doesn't know exactly how the medical aid works. So they will comply, do what the medical aid wants because they don't want to lose their medical aids because they need it. So it is unfair in all those areas because it becomes a threat. As they, if I may, I'm allowed to make an example. If me, I'm scared already, even if I haven't done anything. So it's the same thing. When the medical aid phones you, you're worried. I mean, are they going to stop my medical aid? What am I going to do? So it already is biased against the patient, and the patient is ready to comply with what the medical aid wants. And of course, the biggest thing is this memory of a distressed person of a time when they were not actually aware that that's what they have to be doing. Or even the content. Averagely, I mean, the average person doesn't remember, like he said, we don't know how long we've sat here already.
Could I just push further on this discussion you had Ms. Williams. So, I mean, Scheme X is confronted with a claim they believe is fraudulent. What do you want them to do? Because the way to decide whether it's genuine or not may include contacting the patient to find out if the patient is not being defrauded by the doctor.
That is why our proposal is that there must be an independent audit body that must develop systems for auditing psychotherapy. We have not, as an industry, had schemes. All stakeholders must sit down and agree on an ethical way of verifying psychiatric services. And I do not believe that we should compromise ethics and care of patients today because the industry has not done that and used the wrong ways of doing it. It's like you want to catch a murderer and you actually commit a murder. So we can't do wrong things today because we have not stepped up as an industry to find a way of verifying psychiatry. I don't want to say psychiatry services, all psychotherapy services, whether it's done by a psychiatrist or a psychologist or a social worker.
Just to add to that, I think, I mean, we do agree that it's in their interest to find out if services have been rendered, but it cannot come out in this unilateral way that hasn't been discussed, and the patients are not even aware themselves. If at least maybe, I mean, we want to suggest that there should be a system that should be developed by all sides, you know, the schemes, the doctors, and maybe any other parties that may contribute positively to the discussion of how are services going to be rendered or verified. And beyond that, the patient should be aware that this is going to happen. Because as soon as that phone call comes, the patient is very uncomfortable. And the therapeutic relationship between the doctor and the patient is now destroyed. Because it almost says to the patient that your doctor is a fraud, you know, and it just breaks up everything. And for the patient, for example, that are paranoid, it's a problem.
And I think in that independent body, the users of the services themselves should be consulted. How should their services be verified? They should contribute to the process. We should not psychiatrists, not psychologists, not the schemes should just come unilaterally and decide how the services should be verified.
I mean, I suppose I wonder how this actually works in practice. You can enlighten us, because you see what we've heard is that so claim is submitted, it's paid in good faith within the period of 30 days as prescribed. What you are describing is not the verification of services. It is an investigation usually conducted ex post. And so that's why someone is being asked to recall whether something happened 3 years earlier. You know. But it's not that the scheme is trying to find out whether they should pay the amount, because they pay the amount on their submission, on their version in good faith. So you would say, well, in that event, there is no need to presuppose that I've committed fraud, because you can decide a better method of gathering the facts, and there's no urgency in doing it, which would require a direct contact with the patient, who incidentally is also a member of the scheme. And so they have a separate relationship, which contractually entitles the scheme to contact them anytime.
Yes, Advocate. It's actually, strictly speaking, it's not verification of services. I agree with you. They would have paid. It's actually probably an investigation into fraud. But we are saying that we are proposing that there should be, because the schemes pay in good faith, there should be a way, built-in system that can audit psychotherapy, so that everyone can trust that what they are paying for trusting is actually happening. And it's not something, auditing of psychotherapy or clinical audits are done in other countries.
I always thought that the issue about this particular occupation, and that's what you're objecting to, is that specifically because of the nature of the patients that you're dealing with, it is inappropriate to get these calls that are investigative from the medical schemes, because ignores the particular nature of the vulnerability that your patients are faced with. But the problem I'm struggling with is that when you were asked the same question by Ms. Williams, you seem to equivocate from the principal stance that you shouldn't be speaking to mentally ill patients because you are aggravating their anxiety.
Maybe I don't understand the question well. I don't think we can say the schemes must never phone a particular group of their members. As I've already substantiated that, so sometimes they develop programs to support their members. So to call
That's not the issue is they are investigating and they are accusing, as Dr. Siape says, they are accusing their service provider, the doctor, of committing a fraud.
Yeah.
The question that is within our scope is when they're doing a Section 59, are you saying you object to them conducting that investigation by the direct contact with the patient?
Can I just add to this? I mean, can we separate out situations where the scheme is involved in some kind of managed care in relation to psychiatry? Because I think that is quite distinguishable. Perhaps that'll be helpful just to understand your position.
Yes.
So it's in a Section 59 investigation context.
No, we object, thank you for the clarification. We object to the calling of the patients for investigations. We don't have a problem when they're calling them for other reasons.
Okay, but to carry on this point, you've accepted that there's some difficulty that the schemes face in verifying whether services were offered per se. There are two mechanisms to do this. One is you phone the patient, and there seem to be some issues in relation to that. The second is you engage the psychiatrist. Now, in your submission, you've spoken about your objection to providing psychotherapy notes, clinical notes, which we've heard many submissions on, and we understand those objections. I'm interested if there's some via media. So would a psychiatrist be willing to disclose his or her notes which are redacted so that all patient confidential information is removed, but it provides proof that a consultation took place?
That is also impossible to do. And I'll give you an example. If I had consulted someone important or someone working at Discovery who is fighting with a manager at Discovery, which happens in real life, by disclosing the name that that patient is already consulting me to whoever is already, to another party is already a breach of confidentiality. And
but the scheme in that situation would have the name.
Okay, then the notes themselves of psychotherapy are very, if I were to clear my notes of the psychotherapy, if I were to clear the notes, there will be nothing to use because the session was about psychotherapy. So it's not like, it will not assist the scheme to say the blood pressure, I took it and it was 120/80, because we're not verifying whether I take the blood pressure. It's not just me seeing the patient. The patient can confirm whether they're my doctor or not, but want to confirm whether the psychotherapy did take place or not. So you would probably need the psychotherapy notes to confirm that. That is why we're then proposing that it should be taken out of the scheme. So to a process that the patients, before they even consult a psychiatrist, they know that their notes could eventually go to that body that can verify. And this audit can be done randomly to all psychiatrists.
What if you used timesheets so that the patients sign in and out and it's dated, obviously, with the signature? Would that make any difference?
That some psychiatrists, have done that as a way to verify time. But it's also an extremely difficult process unless there was a software to do it. And in my view, it also increases the cost because when we are done with the session, then we have to go through the process of explaining why they have to sign. Remember, they have not signed, they've been to many doctors, they've never made to sign to confirm that they attend. So it is a possible solution, but it's a difficult solution to implement.
Now, when you talked about, I forgot, but the notes. Yeah, if you say delete like he says, there might be nothing left of the notes. Because remember that psychotherapy is not just about the patient themselves. You know, it's not about Peter only. But in the notes in my therapy, I've also talked about Mary and Jabulani and Tabiso, who haven't consented to their information being included in that. So that means I have so much to delete that in the end you get a date and blanked out stuff, which is not useful. That's the one thing. The second thing is that we have to remember that different doctors write notes differently. I can have a session with you for an hour and write 3 lines, you know, and somebody can have a session with you for 30 minutes and write 2 pages. So the actual notes themselves do not portray how much time was spent, because it depends on how I write my notes on that day. It's also on that day, because some days I'm copious, some days I'm not, you know, or depending on what the situation is. So it doesn't really serve you so much to have the notes if I had to block out all that. And I think, I mean, it might not be an important point right now, but I mean, if you're being asked to produce notes for 3 years, it's a lot of notes. And it's, I mean, it becomes a little bit of a logistical issue in terms of blocking out all those, because in 3 years, I've seen that one patient maybe, if I've seen them, let's say maybe 6 times a year, that means 18 dates of notes for one person. It quite be a lot. With regard to the timesheets, yes, some people are doing it, or we're trying to see if it works, but it also now adds on to the time. And the issue would be that, is that time as part of the therapy, or now that's outside time? Because as Dr. Talatala says, you have to explain to the patient, now we are doing this. And of course, patients are saying, okay, now why do we have to do this? I hear you telling me that. Why do we have to do this? What's going on? You know, it introduces a different dynamic, again, to the therapeutic relationship. That now we're doing something that we never used to do, and is it to prevent fraud? So were you in fraud? What's going on? And what if I don't sign? And it is not irregular that our patients refuse to sign for all sorts of things. We ask to do reports, and they must see the report and sign consent, and they refuse. And it's time, it's the whole process, and you don't know, there's nothing you can do. So it's not completely foolproof. There are catches in it.
There's also what the schemes have suggested that, or will tell us that, no, the patient signed a consent for the release of the notes. It is impossible to get consent for psychotherapy notes unless the patient sits with the psychiatrist and goes through the notes. Because if I'm seeing patient for the first time, I make certain observations that I don't want to share with the patient on the first day that I'm consulting them. That's the first thing. And at times, they themselves will forget about things that they told me that are not related to the diagnosis. They may have come to me, they are related to diagnosis, but they are not the diagnosis. They are not the supporting information for the diagnosis. For example, they can come to me with depression. I'm going to write the findings of the clinical signs of depression and anything that needs to be done. But we're then going to talk about the affairs, about all other things that are not related. They are related, important to the therapy, but not related to make the diagnosis. They may forget that they've shared that with me 3 years down the line. So when they are signing to an other party, even sometimes lawyers do, or insurance companies do demand files from psychiatrists, which I always refuse, because even if the patient signed with a lawyer or with the insurance company, that patient is not signing with fully informed consent, because they have not gone back and read the notes and agreed then that this is what I told you, and this is what I'm agreeing that you must give away. And also, getting them to read the notes then has to be therapy, because you cannot do it carelessly, because maybe you've made comments as a therapist in the notes that could destroy the patients unless the information is shared in a therapeutic relationship and is appropriate. I could have made actually even a wrong impression about the patient, and I've long changed my mind 6 or 7 months down the line. There's no point for me to tell the patient the wrong information that I given, the wrong impression that I had made about the patient.
Is there any specific rule that applies to, a professional rule that applies to psychiatrists in relation to disclosure of confidential patient information?
I don't think, I can maybe correct it, I don't think the Health Professions Council has dealt with it, psychiatry, separately on sharing of the notes. I think it's just treated as any medical notes. Then the process itself, how it's unfair, I said we feel that their samples are non-representative and that this is significant. What they do, I would have seen, let's say, 1,000 patients over 3 years, and I've been paid 3 million rands for those patients over the 3-year period, and the schemes feel that I overcharge them. Let's use that loose language. They will then say they want information on these 30 patients. Obviously, it's tough for them to ask all their 1,000 patients. So they say 30 patients, and they say this is a sample. But that sample is not random. They didn't just go over those 1,000 patients and select 30 patients, then we see what happens. They're obviously going to go for the patients the way they suspect problems. So let's assume we go through the process and we agree on settlement. When we agree on settlement, assuming that they think that in those 30 patients, there was a 50% error rate, they will then, in terms of refunding the scheme, they'll then take that 50% error rate in that biased sample that was selected because it was probative and apply it to the entire practice. We have the view that if we were to go to the sampling, you can select the 30 patients to show the problem, but then when it comes to the sampling for the refund, then we should do a random sample to see if we did a random sample, how often does the process, the error happens. Obviously, if it happens 50%, even in a random sample, then we can apply it to everyone. But as things stand, the percentage that is found problematic in the first sample that was selected, that's the amount the psychiatrist has to pay back. We've then highlighted other problems that exacerbate the situation. The first one is the coding. We do well the view that our coding is outdated and ambiguous, and is the source for the disputes between the psychiatrists and the schemes. For instance, I'll take one code that says you must see a patient between 21. We've written it. The profession has written it. You must see a patient between 21 and 40 minutes. But if you had to look at the value of that code, it's valued at 40 minutes. But a psychiatrist going to practice, since the code says 21 to 40 minutes, then they see 21 minutes, 28 minutes, 35 minutes, anytime. When the schemes are calculating time, they're likely to calculate 40 at the best at 30 minutes and not at 21 minutes. So that's the first problem. So the psychiatrists and the schemes don't agree on that. The second problem, there's 3 psychotherapy codes. One is 10 to 20 minutes. The second one is 21 to 40 minutes. The other one is 51 to 60 minutes. If you then see, let's assume we're signing, we'd agreed that we'll sign for attendance. You see the patient for 18 minutes. Then at minute number 18, you start saying patient must sign, but patient has an argument, doesn't agree with this. You end up to 25 minutes. The psychiatrist, as things stands, either, in fact, has to just charge for 20 minutes, even though they've gone to 25 minutes, because the schemes only recognize from 30 minutes to 40 minutes. This time between, a very critical time, the time between 20 and 21 minutes and 30 minutes is not really paid for, which is a source of dispute. And on follow-up psychiatric patients, usually if you're seeing a psychiatric patient, you most likely will take an average psychiatric patient will take an hour in the first session, but the follow-up sessions are usually around anything between 15 and 30 minutes. So that period between 21 and 30 minutes is a significant period that should be funded for, because it does cover a lot of follow-up psychotherapy sessions. So we do propose that the coding needs to be updated by the entire by the profession, and presented to the industry. But the industry must be willing to cooperate and come to the negotiations and accept what is reasonable. Why we think the coding should be, or how we think it should be reviewed, and we're willing to negotiate this. Instead of having these long periods, we should have 10 minutes periods that are more accurate for the time spent and And we, after an hour, it should go back to that 1 hour. In terms of how much we paid, it can stay the same as how much we paid for an hour. But instead of having that hour only charged at an hour, we should have 10 minutes blocks. And I think that in that way, there'll be less ambiguity about we think that there'll be less ambiguity about the time spent and the coding.
Can you just tell me about coding? Because in other submissions, the problem is that there is no coding at all that is standardized and applied and is known across. In psychiatry, is there standardized coding? Because you talk about ambiguity, which suggests that a code exists, but it's ambiguous.
Yes, there are codes for treating patients. I would assume all disciplines, otherwise the schemes wouldn't know how to pay for the codes. So the codes, I think, were originally developed by the South African Medical Association, including the psychiatry ones. The profession would, obviously, within South African Medical Association, psychiatrists develop them, and the profession is supposed to improve them as we realize problems. So there is a coding, a standardized coding for charging psychotherapy, and there is a standardized coding for doing consultations in psychiatry. There is a coding for everything which we charge for.
But there are several different institutions that have codes. SAMA is one of them. There's also the RPL that we've been referred to, and the ICD-10 codes and so on. So are you saying that the standard code used by psychiatrists is the SAMA codes?
Maybe there's been a bit of confusion. There is coding for charging, if I were to use that simple word. Like coding for charging, whether you are doing an operation or you are GP consulting, that is what you use to charge. There's coding for the diagnosis. That will be the ICD code. So that is a code for diagnosis. For instance, you've got depression, then you've got F32.2. That's a code for the diagnosis. Different from the code for charging. I've seen you for an hour, therefore I charge you code 2975. And then the reference price list, that was a process to allocate costs to the code for charging, which then went through its own problems and was eventually cancelled or
it was set aside by a court
yes.
eventually, but is a SAMA code the one that psychiatrists use?
Yes, it is.
For all medical schemes, it's the same that you would use in your billing.
Yes, it is the SAMA code. Yes, it was developed by SAMA, but the profession fits into it. Yes, but it is the same code for all psychiatrists.
Mr. Talatala, on that point, then do all the schemes and all the administrators for psychiatry accept that the SAMA code is the Bible?
Sorry.
Do all the schemes and all the administrators accept that the SAMA code 2019 is the Bible for psychiatry coding?
Okay, that's where the problem arises. They do not, the schemes, that's why I was also even submitting that the changes should be accepted. The changes that we're proposing will be in the SAMA code, we'll be updating the SAMA code, but the schemes do not accept the latest coding. That's one of the reasons why there will be disputes and ambiguity. They will not accept, even if we did update, because the SAMA code for psychiatry has to be admitted by psychiatry, and we submit to SAMA. Coding experts will then look at it and make sure it makes sense and approve it or not approve it. Even if we go through that process for next year with these innovative changes that we think there should be, it is not guaranteed. In fact, schemes are most likely, I think, unless things change, they will not accept it.
Yes, Dr. Siape.
Yeah, with the coding system, Advocate Williams is saying is it their Bible. I think that was a good analogy because there's so many interpretations to the same Bible. Same with the coding. You know, as Dr. Talatala mentioned, you know, the one code of 20 to 40 minutes. Yet if you see the patient for 21 minutes in code, that's code that says from 20 minutes, you actually will be in trouble. And yet that's what the code says, because the interpretation is different, because some schemes will accept it because it is 21 to 40. Some will say no, it is too little, it should go to up to 30. You should start to code at 30, despite the fact that the code starts at 21. So already the interpretation is not the same. Another problem that psychiatrists are falling into is the fact that the codes do not include all the other work that the psychiatrist must do to help with the diagnosis, to help with treatment, to help with management of the patient, whether it's to get collateral, whether it is to communicate with the boss, whether it is to communicate with other medical professionals with regard to the care of the patient. No code covers that, and yet it takes time. So you'll find that even if you have worked 12 hours, 4 hours have actually been to communications and things like that, which are not included. So it already causes a problem, because somebody might be inclined to then add that time to the supposed to be psychotherapy or consultation, whereas the new codes that we are proposing would include all the time that you spent for that patient.
Sorry, just to clarify then, so the distinction is, or what you're saying is that the schemes will use the SAMA manual, but the interpretation of the codes in the SAMA manual will differ between the psychiatrist and the scheme.
The interpretation by the scheme will differ.
Well, the interpretation between the two of you is what I'm saying.
Can be different.
Will be different.
Yes.
So it's within one manual. It's not that the scheme applies another system or another code and says that's what and you've used the wrong codes.
It's within one manual, but maybe a different version. Remember, the professions have been updating the codes over the years. It's within one manual, but a different version.
Yes.
No, I think the problem is still that the evidence we had was that some schemes are used in 2006, and yet there is a 2019 version of the SAMA code.
Yes, that's where the problem happens. It's the same manual, different versions. Schemes may want to, especially when there's an investigation, they may want to stick to the 2006 version, and the psychiatrists would have, some psychiatrists were not even psychiatrists at the time, they would have been exposed. I don't think I've actually seen the 2006 myself. They would have been exposed to the latest version, so they will be using the latest version. And that would cause the problems of interpretation, the ambiguity.
Can I just ask one more question about the coding? And this is with reference to a specific example that you've given us, this 2974, and the problem that arises with it. And is your submission that if you see a patient for 21 to 29 minutes, I think, you for some schemes can use that code, and for some schemes you can't use that code?
Yes, there are schemes who they won't tell you upfront that for our patients we want 30. It's not like they would have told you. But when there's an investigation, they will not accept 25 minutes or 28 minutes.
So are you saying that that code is the subject of clawbacks in terms of Section 59, where you've used it to charge for 21 to 29 minutes?
It's the most utilized code by the psychiatrist. It is a subject for clawbacks, but I don't want to be strict about that, because the longer the code, the higher is the risk of schemes disputing it and clawing back. It's that the 1 hour one, psychiatrists don't use it as much. In fact, if a psychiatrist chose to work correctly and decide to see 8 patients a day and see them 1 hour each and spends 9 hours in their practice, and they do psychotherapy, and I've got a psychiatrist like that, who does psychotherapy only, that psychiatrist is guaranteed to have an investigation.
Guaranteed to have an investigation?
Yes, that would be an outlier. Not that they've done anything wrong, but because there are psychiatrists like that, we do need them, who are not busy with the rush of emergencies and short consultation and running to the medical ward, who will set aside time to do a certain type of psychotherapy and do it over an hour, for instance, per patient, and not see many patients per day, see 7, 6, 8 patients per day. But that will make you stand out, and you'll be investigated. And I've had a psychiatrist investigated because that's how their practice works. And that psychiatrist does not even prescribe medications. They are doing a type of psychotherapy that fits to that.
And they would be an outlier, they would be picked up because they use the code for an hour consultation.
No, they'll be using an hour code,
Yes.
but they'll be the only ones who are using that
Yes.
code. And it's a longer code, it's a more expensive code, and then the schemes will think that they are being defrauded. May I move on? Yes.
Please proceed.
We've already covered the increasing utilization of mental health services, which is a problem for us. We also do think that, and that is why we need an independent body. Firstly, health has got too many transactions as a discipline. Mental health care is even worse. There's increasing number of patients that need care. There's increasing hospitals.
The example you gave in your previous exchange with Ms. Hassim, do you have an actual case of someone who was using the longer code, but because they had spaced out their consultation to an hour and 6 patients a day, and the system, you remember that your initial point was the system contains a design flaw because it picks people that it shouldn't pick. Who is this person? Do you have their details? Can we ask the scheme to explain why their system picked this person?
We've got the person. I've not asked the permission in preparation to disclose her name, but if she agrees, we'll share the information. Her dispute with the scheme went on for a very prolonged period of time. So I'll be sensitive in how I approach her, but I will ask her if she's willing to share the information.
What was the outcome of the dispute?
After months of engagement, the scheme left the investigation.
And
I
was
think
she
that's left
placed on
unresolved.
indirect suspension or anything during the time of the investigation?
I can't remember if she was, but I know that the investigation went on for a very long time to her greatest distress, and she couldn't practice some of the time because she was now engaged in this
And which scheme was it?
discovery.
But we quoted, we can't share her name because we already didn't ask her, we didn't ask any of our members whether we should share their names. So with the increasing money that's being spent on mental health, we can already assume that there's gonna be fraud in mental health. And that exacerbates the situation, but I think if we dealt with the audit issues, the errors, and separate them from the real issues, then we can find the real fraudulent people who may actually sometimes not even be psychiatrists, but who are still defrauding, whether it's the hospitals or other practitioners who are actually defrauding the system because of the exchanges of money within the mental health care space. So in summary, we are proposing that we should, the psychiatric coding needs a review. We've emphasized the point that we need an independent body to audit psychiatric private practice, coding, services, utilization, and psychotherapy. And audit of psychotherapy, we can learn even from other countries, it is done. And the other part, I think, with the increasing utilization and the increasing burden of mental health care, we need to start thinking out of the box and reorganize mental health care into a value-based care that is less hospice-centric and that is based on outcome measures. And I think if there was a system of making sure that the psychiatrists can themselves report their outcomes and psychiatrists be judged on the value and the outcomes they produce, most of these issues that we're dealing with here would not be even an issue to be discussed. I know it sounds difficult, and it sounds like we are suggesting something big that can only be achieved far away. But if you look at mental health care in South Africa, it's not going to survive. It's going to crash with the number of psychiatrists that we have. And we'll keep building new and new hospitals indefinitely unless we change the model of care that we have. Thank you.
I mean, what's the change on the Section 59 that you have in mind? I mean, that is not to, underestimate the importance of the structural changes. I think, as you explained at the beginning, we've got a social and an economic problem in the country, and that is exacerbating the problem of mental illness. And so it's a long-term process to think about how to reorganize society in order to reduce the incidence of mental illnesses. But in that, what we are dealing with is a narrow one, which is the abuses attended upon Section 59. So the one is we need an independent body to administer. Would you say it must administer Section 59 in its entirety, so that it's not left to the power of the scheme versus a vulnerable doctor?
Yes, that in terms of Section 59, that's the main submission that that's our main submission, that we should have an independent body, so that it's not left to the schemes, but also so that we can develop ethical ways of dealing with difficult issues like verification of services.
I mean, I would still like the underlying data that you were talking about and the specific examples, because the plan, once we've finished this current session, is that we need to put evidence to the schemes. We don't want to say that Dr. Talatala said a doctor in Soweto experienced this problem, because the immediate answer is going to be which doctor.
Yes, thanks, Advocate. I'm hoping that my colleague did make notes of all the...
No, what we will do, we will send you a formal letter with a list of items that we would request.
Thank you. That would be easier for us.
All right. Will that be all? All right, it remains of me then to thank your association for the written presentation and your attendance today. We will be in communication then with further information that we may request.
Thank you.
Thank you.
Thank you, Advocate.
Thank you. We will adjourn until 3. I think the next presentation is at 3, so we will adjourn for 15 minutes.